about the placenta and its role with respect to nourishing the young while it's in the uterus. And the placenta, as we can see within the right-hand image, is rich in blood vessels, and those blood vessels are both maternal and fetal in nature. So the maternal and fetal sets of vessels are found in really close proximity to one another. So you see there's a maternal portion of the placenta, there's a fetal portion of the placenta, and this close proximity allows for an exchange to take place. There is also going to be the chorionic villi or villus singular that will have capillaries. But what we can also look at when you see this visually is the high level of folding that occurs, which helps to increase surface area. So we have the capillaries there where we can have nutrient exchange, gas exchange, other solutes, and the nutrients and oxygen from the mother are going to be carried through the maternal arteries. And then from there, the blood will pool in large areas of the fetal placenta that surround the fetal capillaries. And so diffusion based on concentration gradients will occur. So solutes diffuse from the maternal blood into the fetal capillaries, and there they can flow into the umbilical vein. And in turn, things like waste, carbon dioxide, those can travel from the fetus through the umbilical artery to the placenta and then diffuse into mother or maternal circulation, and then eventually get released through the mom. So based on this type of organization and the movement of these nutrients or waste, there is actually not explicit mixing of maternal and fetal blood. And so this comes back to a concept of erythroblastosis fetalis, or the Rh factor, and how that can cause an attack if there is an ability to sense that the Rh factor is not inappropriate, but incompatible with the mom. And this normally does not happen during fetal development because of this discrete separation of blood that's seen here, but it's normally through events like childbirth in which that rupturing or mixing of blood occurs that starts to initiate that event. And this is largely why the first birth, when you have this kind of Rh incompatibility, normally doesn't have any negative ramifications or negative impact, because that response normally doesn't happen until we're at the point in which the fetus is exiting out of the birth canal and so is no longer going to be subjected to any possible attack by the immune system of the mom. So why is that blood type information with respect to Rh factor important to factor in during pregnancy? And so here we have the example of erythroblastosis fetalis, also referred to as hemolytic disease of the newborn. And it's really coming down to Rh factor and how the body responds to the presence of Rh antigen. Now, as a reminder, in contrast to the ABO blood group, the presence of Rh antibodies is really elicited through stimulation of an antigen. So someone who is Rh negative in the absence of exposure will not have anti-Rh antibodies present. And someone who is Rh positive should not have Rh antibodies because that would yield agglutination. So in this scenario, we have an Rh positive father, Rh negative mother, which means there is a possibility that the fetus can be Rh positive just based on genetics and setting up that Punnett square. Now, in thinking about what could be happening here, this would be an initial production of anti-Rh antibodies that can occur if a barrier breaks down between maternal and fetal blood. As we've discussed, they're meant to stay separated. Now, when it comes to this possibility, and it can be a result of birth, which is what this is trying to indicate. So that's one mechanism in which we can start to elicit a response, or sometimes if there's a miscarriage, then there can be kind of a breakdown between the blood sources for both mom and baby. But in looking at this, what we see here is a breach of that placental barrier. So now we have these Rh antigens that are found within maternal circulation, and the body's going to respond. And so the response is going to be the essentially amplification of anti-Rh antibodies. We're secreting them, injecting them from B lymphocytes, and now they're circulating around. So what would happen, or what would be harmful to this, would be if there is a second child that also presents with Rh positive, because antibodies are capable of making their way across the placental barrier. So if the mom already possesses anti-Rh antibodies from her first exposure, then they're going to cross the barrier and start to interact with the Rh antigens of that fetus. When it comes to this process, it's easier to prevent than to treat. And if an Rh negative woman gives birth to an Rh positive child, she can receive an Rh immune globulin. And one of the terms or names for that is called ROGAM. And when it comes to the treatment mechanism, the immune globulin will bind to fetal RBC antigens so that the maternal immune system does not become stimulated, and therefore it does not produce anti-D or anti-Rh antibodies. It's common to give ROGAM in the third trimester as well as at birth to a woman who is Rh negative. So this was something that happened to me with this first child, because again, looking at that genetics, being an Rh negative individual means that the possibility for this was real. And it was good that we had that genetic information going in because her blood type is actually B positive, right? So she does have that D antigen. So having that knowledge and going in with the information, knowing how genetics works, having genetic counseling was very beneficial from both understanding blood typing and agglutination, as well as understanding autosomal recessive disorders. Now, if we're thinking about a fetus that's going to not be treated appropriately, meaning we don't have the ROGAM treatment, the mom is generating these antibodies and starting to interact with the fetal antigens inappropriately, the infant would be extremely anemic and would try to regenerate more red blood cells as a result of their decline due to antibody attack. And that would lead to a higher population of immature erythrocytes entering circulation because they're trying to increase that hematocrit at a rate that really can't be done through the proper process of erythrocyte kind of maturation. So you want to think about what would be the treatment, what impact that has, draw a little bit of your knowledge from the immune system as it relates to this. We're also incorporating a heavy amount of the genetics that allows us to understand what the impact would have. So this is technically including understanding antigen-antibody interactions, which is something you've already gone through in your earlier content, but it is still very relevant with respect to genetics.
Now, maternal changes are going to take place with certain hallmarks that are seen in various regions or trimesters of fetal development. Now, within a non-pregnant female, we can see the uterus is about the size of a fist. Think about its proximity to the urinary bladder. Belly button here, diaphragm here, which we know from respiration, and then the mammary glands are rudimentary. Okay, now at pregnancy, we can see that there is a transition with respect to the mammary glands, and as time progresses, that is going to change with respect to the lobules and lactation and the sinus, as was discussed in an earlier voice thread. When looking at the progression from 4 months to 9 months, we can also see how the uterus is expanding and changing as the size of the growing fetus changes. And so eventually, towards the end of gestation, the size of the fetus is such that it's pressing down on the bladder. It's taking up space really proximal to the diaphragm. And so, as you might expect, there's going to be some limitations with respect to breathing because we know that the diaphragm plays a role in terms of expansion or space within the thoracic cavity. We would expect for the amount of urination or desire to urinate to also increase because the amount of space that is seen within the bladder is going to be diminished. And there are a ton of other changes too. If we relate this back to content within the cardiovascular system, there's an increase in blood volume. And so there can be an increase with respect to the amount of pressure on the lower extremities, which can increase the likelihood of varicose veins. There are hormonal fluctuations, which can impact the digestive system. There can be nausea. The timing of nausea, they often say, ends after the first trimester. What I've always said to my A&P class is that I no longer utilize how, the mom would feel based on trimester from my own personal experience because none of that adhered to what they have in standard textbooks. And so I often say that, each individual that's carrying life is going to go through, a different set of events, but the one thing that you would expect with a successfully growing fetus is a change in size as time progresses. And with that increase in size, you would expect for there to be increased stress on different areas of the mother's body. And those things can revert back for the most part to normal. As I said earlier, the uterus will never go back to exactly how it was in the non-pregnant stage, but a lot of things can go back to normal to a certain extent after a certain period of time. So the task is not to know all of the maternal changes that take place because they're pretty long, and I go through a lot of those in a different course. We're not going to do that here. So really just focusing on the size differences as time progresses and how you would think that increasing the amount of space that the fetus is taking up, thinking about the impact that would have on the normal everyday behaviors or expectations that would be seen within that pregnant woman. Here we can see how labor can take place as a positive feedback mechanism, and this should occur when gestation comes to an end. When it comes to the process of childbirth, this is normally initiated by the fetus, so it plays a really significant role in determining when it's ready to leave, and hormonal changes will help to initiate the process. Now, when it comes to the relationship between mother and fetus, there can be a release of estradiol from the ovaries, and that can help to activate oxytocin receptors on the uterus. There is also an increase in prostaglandins that are seen in response to those changes in estradiol levels as well. But when looking at the right-hand side, we can see the role that oxytocin is playing within this process. So there's oxytocin from both the fetus and the mother, and that oxytocin is going to help with contraction of the myometrium, which is one of the layers within the uterine wall. And that uterine contraction helps with the process of stretching the cervix. And with that stretched cervix, that can promote additional contraction. So that would be a positive feedback event. So oxytocin can stimulate the uterus to contract. It can also stimulate the placenta to make prostaglandins, and that in turn can stimulate more contractions of the uterus, more contractions, more stimulation, more contractions, more stimulations, until that stimuli dissipates. And that would be after the fetus leaves the birth canal. So ultimately, we're seeing the role that hormones can play in terms of eliciting uterine contractions that allow for childbirth to occur. And we want this to be a positive feedback event because we want to keep initiating these contractions of the myometrium until the fetus is born. Stage 1 is dilation of the cervix, and this is the longest stage, so this can last for many hours when it's the first birth, but it can also last for a few minutes if a woman has previously given birth and this is their second or third child. I will say that this statement is applicable for births that are not induced. So, for example, I have 2 children, but for both of my children, induction was required, in which they had to, synthetically or chemically kind of induce my body to go through the stages of labor. And in that instance, regardless of if this was my first child or my second child, the amount of time that it took to go through that process was actually pretty long. So the statement of dilation of the cervix and the timing that it takes in terms of first birth or a birth after the first one, this is going to be in a quote unquote natural way. So a way in which the body naturally decides that it's ready to go into labor rather than being induced. Now, when it comes to the dilation stage, there's going to be a change with respect to the cervical canal. So a widening that will occur, and the maximum diameter that it can reach is 10 centimeters, and that's about the size of a baby's head. And during the process of dilation, the fetal membranes oftentimes rupture, and the amniotic fluid would be discharged at this time. So this is the idea of water breaking. Now, at this stage, you're really thinking about how effectively can the head make its way out of the cervical canal, and they will check to see the level of dilation as time progresses within the labor if you are being assisted within this process. So compared to the dilation stage, the expulsion stage is relatively short. So that can be in the range of minutes. So it can be 30 minutes to an hour. And if it is not an individual's first child, that time may be significantly reduced. And when it comes to the expulsion stage, this is essentially the time from the head entering the vagina until the baby is expelled entirely. When it comes to the process of expulsion, the delivery of the head is the most difficult. And it might seem like the shoulders would be just because they are broader than the head is. But during the process of childbirth, the body will shift in such a way that the shoulders actually come out relatively easy. So the most difficult part is going to be the head exiting out of the birth canal, and the rest of the body will turn in order to accommodate the easiest level of navigation out of the pelvic outlet. Now, during this time, during the expulsion stage, it's possible that an episiotomy may be performed. And that will be an incision that's done in order to widen the vaginal canal, or depending on the doctor, they may opt for natural tearing to be utilized if it does occur at all. So the third stage is the placental stage. And when it comes to this, there is still continued contraction of the uterus after the baby has been expelled. We need to ensure that the placenta is removed during this process. The placenta is non-muscular, so it's not capable of contraction. We want to make sure that the placenta and the amnion and the other fetal membrane is entirely removed at this stage. When it comes to this process, sometimes there may be a slight pulling on the umbilical cord in order to achieve that, but it's important for the afterbirth, so the membranes that were there, to be inspected to make sure that all of it's been removed. If certain structures remain, then it can lead to postpartum hemorrhaging, which is something that we'd obviously want to be avoiding. So here's just a small connection with the immune response and being able to tolerate the embryo and fetus, and the distinction of these two just has to do with how far along in the process of development we are. But when it comes to the mechanism that a woman goes through in terms of saying, okay, well, this is not a foreign entity within me, that's not properly understood, but it's thought that the individual is in kind of an immunosuppressed state. And this kind of makes sense to me, and they'll see that things like autoimmune disease are less severe during pregnancy because that is going to be kind of an amplification of the immune response. But then also it's often said that women that are pregnant get sick very easily. So that would also help to support the idea of suppressed immune response as well. So it's a nice way to connect the immune system and your knowledge of it because you've recently learned about it in both of the classes.
So I'll go through each of these methods of birth control. You do want to think about which reproductive system these are being applied to, meaning is it the male reproductive system? Is it the female reproductive system? And then use your knowledge from earlier material regarding cycles and hormones to think about the impact that these methods would have on those processes. In panel A, we have male and female condoms, which are an example of barrier methods. And so a barrier method is designed to prevent sperm from getting into the vagina or beyond the vagina. And the barrier method, or these condoms, are most effective when used with a chemical spermicide. And that's available in multiple forms. Now, when it comes to the male condom, that is going to be composed of latex or rubber or an animal membrane like lamb intestine. And that's going to be a way in which semen can be collected, and so that's going to prevent it from entering the vagina. Now, it's inexpensive, it's convenient, it's pretty reliable when used carefully and accurately. And when it comes to Americans, the data from this, I think, is relatively recent. About a quarter use this contraceptive only, and it's ranked second to birth control pills with respect to popularity. Now, notice that there are female condoms listed here too. These are less used, and this is composed of a polyurethane sheath with a flexible ring that's seen at either end. So this one is the female condom, and here you can see the two rings on either end. Now, when it comes to the female condom, this can sometimes be a little bit more difficult with respect to application and insertion, but male and female condoms are the only contraceptives that can also protect against disease transmission. But when it comes to the animal membrane-based condoms, which are seen in the male condoms, those are porous to HIV and to the virus hepatitis B. So those cannot be utilized as a means of protection from those particular diseases. Next are some female-specific barriers, which include the diaphragm, cervical cap, and sponge. And these methods can block the cervix so that sperm cannot pass into the uterus. When it comes to this barrier method, the same as male and female condoms, the efficacy can be increased through the application of spermicide. And spermicide is something that can trap and kill sperm. And one of the most popular versions of spermicide does this through disrupting the plasma membrane. Now, while it's listed independently, spermicide all by itself is not a good protective option because it has a pretty high failure rate if used alone. So it really should be used in conjunction with either A or B. And some condoms will come with spermicides already applied. Next, we head into examples of some hormonal methods. And the goal within a hormonal method is to inhibit the process of ovulation. And that can be achieved by suppression of gonadotropins. So without FSH and LH, we can prevent follicle maturation. Estrogen levels are not going to rise. There's no LH surge. There's no ovulation. When it comes to oral contraceptives, they can be composed of estrogen and a synthetic version of progesterone called progestin. And typically there's a 28-day pack in which 7 of the pills will lack the hormones. And the lack of hormones will allow for menstruation to occur during that 7-day window. And the idea behind these oral contraceptives is that it can mimic pregnancy so that the ovarian cycle and ovulation are temporarily suspended. In panel G, there is an IUD, which stands for intrauterine device. And these are springy T-shaped devices that are inserted through the cervical canal into the uterus. Some IUDs act by releasing synthetic progesterone, but others, like the one that's shown here, have copper wire wrappings or a copper sleeve. And the IUD irritates the uterine lining and interferes with the process of implantation. And copper IUDs can inhibit sperm motility. When it comes to an IUD, these can be left in place for a pretty long time. Here we go through some more permanent methods of birth control. So the first focuses on the male reproductive system, and this is a sterilization technique called a vasectomy, in which the ductus deferens is cut and ligated, and as a result, sperm can no longer pass through the male urethra. Now, a vasectomy does not impede spermatogenesis, so there is still production of sperm, but that sperm will be reabsorbed. This process has no impact on male hormone levels, so it does not decrease male sexual response or sexual arousal. Semen is still capable of being generated as well because semen is an incorporation of secretions from various glands, and that can still be generated based on the location in which this cut occurs. Now, when it comes to a vasectomy can be reversed, but there's no guarantee of fertility restoration. An example for the female reproductive tract would be tubal ligation, in which the uterine tubes are cut and ligated such that the eggs can't reach the uterus and sperm can't reach the egg. In this situation, still, we have normal standard hormone levels, so sexual response is not impeded. You can have a less invasive approach when it comes to modifying the female reproductive tract, which can be tubal implants. And this is a non-incisional sterilization technique. So instead of going through this cut and ligation, there's a spring that gets inserted into the uterine tubes. And then scar tissue grows around it, and eventually it will physically block the uterine tubes. And that's something that they would need to check after insertion to ensure that there is complete blockage. A benefit to going through the tubal implant approach would be that there's no need for general anesthesia, like what's required for tubal ligation.
For this figure, this goes through the different types of means to preventing a fertilization event and at what stage it's able to impede that process. So we've talked about permanent and temporary methods.